A relapse is by no means a death sentence, period. It's not as if everything always has to be immediately and terribly serious. There are many patients who tolerate imatinib very well, and then there are patients who take it for 10, 12 years. My longest-standing patient has been taking it for 24 years. Generally, tumor surgery is not emergency surgery. It's not about taking another week to travel somewhere to get advice before making a decision.
Today's topic is gastrointestinal stromal tumors, specifically when they are locally confined, meaning in an operable condition. Accordingly, we will be discussing surgical procedures extensively, but not exclusively, because there are also many possible measures available both before and after surgery. Today we are speaking with Professor Hohenberger, who is a great expert in the field of GIST.
Hello, thank you.
We are talking about a situation where the diagnosis has already been made, and it is defined as locally confined and operable. However, we are also producing additional videos. So if this particular diagnosis doesn't apply to your specific case, please stay tuned. There will be other videos that will be relevant to you. My first question would be, what does operable even mean?
Operable means that in this sense or in this context, a tumor can be removed. More precisely, one would define it by saying that it can be completely removed. And for malignant conditions, it means that it can be completely removed with a safety margin, so that the pathologist confirms it's entirely within healthy tissue, a so-called R0 resection. This is what one should consider operable in the context of GIST. In principle, almost everything is operable. It depends on the specific situation. If you have a bleeding tumor that cannot be treated in any other way, then it's first just about stopping the bleeding, for example, and the R0 resection becomes secondary. But what we're discussing today, a locally confined GIST, means it is removable in healthy tissue with an appropriate safety margin.
We just mentioned that additional therapies might still be necessary, perhaps even before the surgery. This therapy before the operation is then called neoadjuvant. Is that correct? And when or why is that necessary?
Let me first try to explain the term itself, neoadjuvant. That means it's a supportive measure for the operation. Help is called adjuvar in Latin, and that's why it's adjuvant. If I were to say now that I utilize this assistance even before the operation, to reduce the tumor's size or to destroy it, to eradicate it completely with medication, then this is called neoadjuvant, meaning it's a new adjuvant approach and it takes place before the surgery.
And you had just said that the tumor can even be completely destroyed. Do I still need an operation then? Or does that mean none is needed at all?
Yes, you actually need it, because you generally do this for what are called locally advanced tumors. These are tumors that are either particularly large, and if they are located, for example, in the stomach, one would have to remove the entire stomach or large parts of the stomach just to remove the tumor. If such tumors can be reduced in size with a pre-treatment, so that instead of 11 centimeters, they are only 6.5, then it's usually possible to perform stomach-sparing surgery. This means it's about preserving the organ where the remaining tumor is removed if one doesn't wish to continue with medical treatment. The other scenario is when you ask, why do we have to operate on it then? You don't know for sure if there are still living vital tumor cells in that tumor. And we also observe that among tumors which have reduced their size by half, some exist where the pathologist, following their surgical removal, can no longer detect any vital cells. However, there are also other types of tumors where the pathologist still manages to find 15% vital tumor cells, which very likely would have regrown at a later point in time if the tumor itself had not been completely removed. Therefore, neoadjuvant means pre-treatment, influencing the tumor, reducing its size, killing it off, and then removing the residual tumor, the part that remains.
How exactly is the operation planned? What are the necessary steps involved? And when can one perform minimally invasive surgery, and when is it simply not an option?
Well, we should differentiate between two distinct situations. The normal, in quotation marks, diagnosed GIST, which can be located in the stomach, in the small intestine, and sometimes even in the rectum. It's precisely about where it is localized, what is its exact size, and the most crucial question is how to plan this. Who will be performing this surgery? Does the surgeon who is being considered for this procedure have experience with it? This is somewhat of a transitional lesion, a 2-centimeter gist, which is located centrally within the stomach. It's not a major undertaking to remove this, provided it can be resected laparoscopically.
That's less invasive, right?
If it's resected minimally invasively, that's really not an issue. For small bowel resections, a segment of the small intestine, even if the gist tumor is 5, 6, or 7 centimeters in size, you'll need a safety margin of 1 or 2 centimeters, which means removing a small bowel segment of about 10 to 12 centimeters, and then sewing the small intestine back together. This can also be done minimally invasively. The rectum is already a more challenging situation, because gists located there either have a very low risk of them returning or a very high one. There are no intermediate forms. Intermediate, moderate risk does not exist in the rectum. So for rectal tumors, you absolutely need to consider beforehand. Does the surgeon have sufficient experience with these specific types of tumors? Because the operation for gist is quite different from that for rectal cancer. With rectal cancer, I have to remove the lymph nodes. I don't need to do that for gist. However, when dealing with gist, the primary goal is to meticulously reconstruct, for example, the rectal ampulla. This is the crucial part of the rectum where stool is temporarily collected and stored before its final evacuation. So these are the 3 primary situations.
And now for patients, the really big question that comes up is, as we've mentioned, gist is, of course, a rare disease. We've already explained this in the films we've made about the condition itself. So how does a patient now find a surgeon who is truly suitable for a gist operation? That's quite a significant challenge that patients often face.
So the standard answer, of course, is a sarcoma center. There is always someone there who is capable of operating on gist. However, it must be noted that many gists are often incidental findings, or more specifically, they are discovered in the stomach, where these gists might bleed superficially, or gist is accidentally discovered when checking to see if there is reflux from the stomach into the esophagus. Then an endoscopy is performed and a gist is discovered. And these are usually areas of gastroenterology. Initially, not everyone thinks that there could be something like a sarcoma or something malignant behind it. That means such smaller tumors, which are in an unproblematic location, so not at the entrance and not at the exit of the stomach, can certainly be adequately resected by experienced abdominal and visceral surgeons, also minimally invasive.
Should one then ask if he already has some experience?
Definitely. First, you should know the diagnosis before operating on anyone, just like in any other aspect of life. Before you do anything and just say, "Oh, it'll be fine, let me just see what the histology is." Occasionally, it's really difficult to biopsy these gists, especially when they're small in the stomach wall. But that's not something that will cause any problem. Everything else, for example, from 3 centimeters, must be biopsied. And if I know it's a gist, then I just have to ask, do you have experience with this condition? Generally speaking, tumor surgery is not an emergency procedure. Even if this gist in the stomach bleeds a little, and you've discovered it through blood in the stool, it has already been growing there for several months. So it's not a problem to take another week to travel somewhere, get advice before making a final decision.
I believe that is a very important statement that you have just made. Now, I would be interested to know, what exactly would be your criterion for having experience with gist?
Well, I would say that having had the experience of operating on 10 gist tumors over a period of time, that's certainly quite a significant accomplishment. It really comes down to how you handle them. These tumors are often very soft and quite friable. So the real question would be if someone has already operated on 10 gists and truly understands what it takes. It's usually technical. If they're not locally advanced, as we just discussed, that you have to reduce them, then it's mostly, with the exception of the rectum, not technically highly demanding, but you have to know what you're operating on.
So, another challenge with GIST surgery is, as we've already briefly discussed concerning neoadjuvant therapy, the extent to which other organs are also involved. How do you deal with that? And when do additional organs need to be operated on or not?
It could be a segment of the large intestine, or it could be a piece of small intestine attached to the gist, and that has to be removed in a similar way, like with a World War bomb. You don't just go there, start digging it out, touch it, and then pull it free. Instead, you bring in a large excavator, carefully move the surrounding earth away, lift the object out, and then safely dispose of the bomb. And it's quite similar in this situation as well. You take what is absolutely necessary to ensure you return to a healthy state in order to completely remove this gist. And that might perhaps make it easier to grasp the reason behind this approach.
And for patients, it is indeed quite often a significant challenge, particularly when other organs are also affected. What possibilities exist for patients to participate in decisions or discussions regarding how the operation will be carried out and what precisely will be done? Is that even truly sensible, or where exactly do the boundaries of what is reasonable lie?
So the patient must generally be involved in deciding what is done, because ultimately they are the one who will have to live with the consequences later on, especially in the event that complications or long-term side effects should arise. That won't cause any pain or suffering to the doctor, but it very well might to the patient. Therefore, they must be part of the decision and say, okay, I'll agree to this, and my questions about it have been sufficiently answered.
When an operation like this is done, do you stay long in the hospital, or can you leave soon?
So nowadays you're discharged from the hospital quite quickly, as soon as you're pain-free, able to walk and so forth. Usually the final histology isn't available yet. Let's say for a gastric gist laparoscopy, which is done minimally invasively, you'll be in the clinic for a maximum of 2 days.
Oh, okay.
Or maybe 3, but usually within 2 or 3 days.
And after that, you can actually go home then?
Yes, it's usually closed with stapling instruments, meaning with metal staples that are used to seal it. You might not be in peak condition yet, but you are certainly well enough to remain at home and continue your recovery there. There's no need to worry. And also after neoadenoma operations, it certainly plays a role what exactly was removed. The combination of stomach and large intestine is generally unproblematic. The combination of the stomach and pancreas is certainly problematic, or can be more problematic, so patients might be kept in the clinic for perhaps 5, 6, 7, 8 days until we are sure that everything is okay. The pre-treatment, just to add that, with imatinib, for example, plays no role in wound healing disorders.
So in contrast to this, if you were to have chemotherapy, then that would be a completely different story.
If, for example, you have received systemic chemotherapy with cytotoxins, or have been pre-irradiated where the surgical area already has a radiation dose, that is a completely different situation. However, neoadjuvant pre-treatment with imatinib does not lead to any increased rate of wound healing complications.
It was just mentioned that patients are discharged home quite quickly after their operation. And then, of course, the question arises, what about wound care? What exactly should one pay attention to? Are there complications where you might need to contact a doctor again? What should be considered then?
Well, there can always be complications. Let's say for the specific spectrum of issues that we've just discussed, complications are actually quite rare. I wouldn't really expect a lot of complications to occur there, but you simply have to go to your family doctor, have the wound inspected once, and remove the plaster when you go home after 2 or 3 days. Whether that involves providing wound care, or if your family doctor offers a special wound consultation or something of that sort, or someone just needs to change the bandages and take a look at the wounds.
With minimally invasive, it's really just small incisions, like 3 precise cuts around the belly.
So in medical jargon, these are referred to as the stamps. You'll have 4 stamps, and at some point, the tumor itself will also need to be removed. Yes, that means there's always an incision that's a bit larger, because otherwise you simply can't get the tumor out. It's then placed into what's known as a retrieval bag. Then it's not pulled openly through the abdominal wall, but rather placed inside the abdominal cavity into a bag, a tear-resistant bag. Very important. And then the abdominal wall is expanded just enough so that you can pull it out. So you make a large incision and take it out, which you can do right away. But there's always an incision made somewhere that's perhaps 5 or 6 centimeters in length, depending on the tumor's actual size, so that the tumor can be removed.
And what if I hadn't had minimally invasive surgery now?
Then there's usually an access incision, about 10 to 12 centimeters long. This is the opening the surgeon uses during the procedure. In most cases, it's closed afterward with staples or absorbable sutures. This information is usually on the discharge letter from the clinic, or it's required to be there. It's always included. It's a legal requirement, stating what medications, when the next follow-up, when which wound check should take place, and that's normally the general practitioner's responsibility.
Well, let's just add it up very simply. Is showering allowed?
Yes, you are always allowed to shower when you have a plaster on, because the vast majority of plasters are waterproof and can easily withstand at least 1 shower, or even 2 if absolutely necessary.
And can I carry my water crate up myself?
I wouldn't recommend it. Let's put it this way.
Because of the pressure?
Yes, you can take the bottles, one in your right hand, one in your left. That ought to be enough. Then you'll just have to go twice or something like that. It's different with something like carrying a crate of water. Anything that puts strain on the abdominal wall, because this is abdominal surgery, should be avoided. Most people do that anyway, simply because it hurts when they tense the abdominal muscles. But you should take it easy on the abdominal wall for at least a month, and if there's a real abdominal incision, depending on its size, maybe even for 2 months. Showering, however, is not a problem at all.
Is there anything else significant to bear in mind?
You need to discuss if you'll have to keep taking medication after the operation, beyond just pain relievers. If you experience pain following the surgery, which for wounds in the abdominal wall is not at all uncommon, in fact, it would be quite normal, then you should take pain medication. That's what they are for.
Once this is all completed and the operation is over and I'm feeling okay again and so on and so forth, then there's always a very big question. How can one avoid a relapse, a so-called recurrence? What possible measures are there? Or to minimize the risk, let's put it that way.
So, one crucial measure is already to make the right decision before the surgery, for example, to shrink the tumor, to at least largely eliminate it through medication. And then the question naturally arises, how big was it? Where was it located? What was its mitotic rate?
What is mitotic rate, or what does it mean?
The number, the overall quantity of cell divisions. You see, the tumor cells inherently strive to reproduce themselves. And the more tumor cells actively divide, meaning that from just one tumor cell, 2 new ones are formed, these specific cellular processes are what we call mitoses. This means if a tumor contains only a very small number of what are known as mitoses, then it is considered less aggressive, possessing a low potential for spreading. If there are many mitoses, and this is the mitotic rate, the pathologist must count and measure them within 5 square millimeters. That information has to be included in the pathology report, and it can take a few days before the final report is available. But it's very important, because together with the tumor size and the location, it helps determine whether additional medical treatment is needed afterward. And if that's the case, we're talking about what's called adjuvant therapy.
And why exactly is localization important?
Because tumors are differently aggressive depending on their location. So those in the stomach are generally the least aggressive. Those in the small intestine are much more commonly aggressive. And those in the rectum are either very slightly aggressive or highly aggressive. And this determines the risk of a tumor recurrence developing in that area. And we differentiate as follows. For a very low risk, no action is required. For a low risk, no action is required either. For an intermediate risk, there is no data showing that it provides any benefit regarding the survival rate. However, for anything that is highly aggressive, there is clear evidence from multiple large-scale studies that it provides a significant advantage to implement a drug-based adjuvant therapy, which both reduces the recurrence rate and improves long-term survival.
Am I understanding this correctly now? So everything from low risk to medium risk, You just have the operation, and it's simply done. Then you're finished, you go home, you enjoy your life, and that's all there is to it, right?
No, it's something you need to check occasionally. That's something one absolutely has to do.
Yeah, naturally.
But that I can truly enjoy life is definitely right.
However, when the risk is high, then medication truly has to be taken.
Yes.
And are there any other non-pharmacological therapies that are also recommended? Or no?
Well, you see, it's actually quite simple. These tumor cells possess a genetic defect, a specific mutation, which is commonly referred to as a driver mutation. These mutations actively propel the tumor cells towards rapid division and proliferation, causing them to multiply uncontrollably. And with a medication, specifically imatinib, you are able to effectively switch off the effects of these genetic changes, which are found exclusively within the tumor cell. This means you essentially deactivate them.
I think that's truly a great thing, because in contrast to chemotherapy, which I'd simply put it, shoots at everything like a shotgun, this is now so wonderfully targeted.
It's called targeted therapy. Targeted. The target, that's the goal. You can turn that off, and you can turn that off very effectively. And for high-risk patients, the therapy is approved for a period of 3 years, because there is study data available for it. However, even after 3 years of taking the drug, relapses still occur if the medication is discontinued. Therefore, studies are currently running for a period of 5 years. 5 years show better results than 3 years. But anyone who has experience with GIST patients has also seen cases and individuals who then voluntarily continued taking the medication because they say, "I tolerate it well, and I'll keep taking it to prevent anything from returning." And then they see that perhaps after 10 years on imatinib, they eventually decide to stop. It's not uncommon for patients to come back even after 11 or 12 years, standing in front of you again because the disease has recurred. And in situations like that, the decision about what to do next is always a very individual one. It has to be made between a physician who has extensive experience with GIST and the patient. It depends on how well an individual tolerates the medication. There are many patients who tolerate imatinib extremely well, and they say, "I'm not stopping it, I'll keep taking it. I've already heard that something could happen." Some patients take it for 10, 12 years. My longest-standing patient has been taking it for 24 years.
So, when you always bring up these specific times, it's simply due to the fact that we can't look that far back into history? That means you now simply have patients who have been taking it for 5 or 10 years already, but we simply have no knowledge about how it was in the past. Because you can't look back far enough now to say that if you stop after 10 or 12 years, then X% have a relapse and Y% don't. Or is that possible?
There are at least no studies available on it.
Okay.
And you can, of course, compile that from the major GIST centers. That is also currently underway. But for that, you first need to have patients who have actually been taking the medication for 10 years. Patients who are still alive after those 10 years and haven't passed away for other reasons. And of course, that can be anything unrelated, like prostate cancer, breast cancer, a car accident, a plane crash, or simply something else entirely. This means the data foundation for this is quite limited. Currently, it's an experience base from GIST centers.
Yes. And just one more thing. If a relapse were to occur, is there always a good chance to still get it under control so that the treatment works effectively again?
That depends on when and on what basis it comes. If you, for instance, as is standard and approved in Germany and throughout Europe, have taken imatinib for 3 years and then said, "Okay, I've taken it for 3 years now," because it's been found that the longer you take it, the better it keeps it under control.
So I understand that the official guideline recommends taking it for 3 years, but your experience suggests longer. If I wanted to continue it beyond that, what would be the next steps?
So definitely longer for specific patients. It's not the case that everyone needs to take it for an extended period. Our standard procedure is to simply continue prescribing it. And should there be any questions or inquiries, we then provide the justification as to why this particular patient has an exceptionally high risk for a recurrence. This could be a tumor, its size characterized by a mitotic rate of 40 mitoses, or an initial rupture. For example, I would specifically examine the area of actual tumor rupture, where the tumor itself has torn. This is generally considered a metastatic disease, but in such a situation, it would also continuously progress and occupy more space.
But what if the patient has stopped taking their medication, for whatever reason, and then a relapse occurs? Can that relapse still be relatively well managed?
It always depends a bit on what it is. If it occurs in a certain place, you can also consider whether to operate on it. In general, it can be managed well with resuming therapy. It's a completely different story when a tumor recurs under adjuvant therapy. In general, this indicates a mutation. That's a completely different matter.
We'll actually be making a separate film on this subject. We'll also be discussing that in much greater detail there. Now, the point is, you're essentially still in treatment as long as the therapy continues. Practically, you're healthy, because then the gist is completely gone, meaning it's no longer measurable. And what about the follow-up care then? How does that process work?
You can either do the standardized tumor follow-up, that is to say, every 3 months, a CT scan, or an imaging procedure. However, the risk is actually at its absolute lowest right after the operation. And typically, the protocol is that for up to 5 years, you'll have follow-up appointments every 3 months for the initial 2 years. Then every 6 months for 3 more years, and then you can stop. It's rather ill-advised because the risk of recurrence tends to be higher the longer the disease progresses. It's not as if you can simply say, "This is now completely cured." Of course, many individuals do achieve a cure, but it makes no sense to perform a CT scan or an MRI every 3 months throughout the first year. This only incurs costs, and you won't discover anything unless it's an exceptionally high-risk situation. It would be smarter to increase the time intervals at the beginning, at least 4 months, maybe even 6 months, and ideally longer follow-up beyond the 5 years. That's why it would be smarter to follow up for longer than to start very intensely, where not much comes of it, and then stop after 5 years.
Can the patient then somehow say, "Okay, I want it this way now"?
A patient might say, "Why do I have to go back there again?" If you extend the interval from 3 to 4 months, you save at least 1 examination per year without them losing any crucial information. In the long run, that's not a problem. And a follow-up? Yes, so that's always individually feasible, and you wouldn't do that with patients who had a 2-centimeter gastric cyst.
That may sound quite unusual for GIST, but relapses can still occur, even after very long periods of time. Does that mean that patients should also pay close attention to their own bodies and take any changes seriously?
An examination is one possibility. You can actually only proceed in this manner if you develop symptoms that you haven't experienced before. Let's say your stomach is distended, bloated, and you feel somehow bigger, without eating more or anything, then that can be an indication of seeding in the abdominal cavity. Liver metastases are generally, as long as they are not 7 or 8 centimeters large, mostly painless. So, for this reason, imaging, and especially imaging that uses a contrast agent, that is the absolutely crucial, the most decisive point when it comes to monitoring this.
If, for example, during a follow-up examination, a recurrence or a metastasis were detected, what courses of action would then be possible?
That depends a bit on what it is. For example, if you have GIST in your stomach and a local recurrence develops in the post-operative area of the stomach, then it will certainly be approached primarily surgically. Depending on its size and how amenable it is to another operation, it can be done again. The same applies if something like that is located in the small intestine. The crucial aspect then is to ascertain whether it's a solitary metastasis, or perhaps the very first of many, or if there are already multiple lesions present. In the majority of cases, especially within the abdominal cavity, these are primarily multiple occurrences, which means that for metastases located in the abdominal cavity, one would typically initiate a systemic medical therapy. For liver metastases, for example, it's sometimes possible to try to destroy them using thermal methods, with a laser, or also electrically, through techniques like electroporation. So there are actually quite a few different treatment options available.
That sounds quite scary.
It sounds scarier than it is. What they do is they insert a wire or a piece of metal directly into the liver, under precise CT guidance and control. And then, at that specific point, you can electrically apply certain currents. You can also apply various frequencies, specifically certain electrical current frequencies. You can also perform microwave ablation by inserting a microwave into the wire. It is essential that they reach 60 degrees at that spot, in the area of 0.5 to 1 centimeter all around these metastases. At 60 degrees, the tissue is destroyed. How you achieve this depends. There are different technologies for that. I don't believe that there are any fundamental differences in terms of their overall effectiveness. It truly depends on precisely where it is localized. Therefore, it very strongly depends on the specific combination of location, size, and experience. They utilize entirely different techniques.
We'll be making a separate video about new developments and progress soon. But I think the key message here is that even if there is a relapse, there are still many options available. The question is whether someone can still be cured, or cured in the sense that the disease can be controlled long-term, for example, by continuing to take the medication.
I have two things to say about this. Recurrence is not a death sentence, period. Secondly, what does healing actually mean? For example, no one is ever truly cured of coronary artery calcification. It's something you manage over time. Instead, you take medication to curb and to minimize the consequences of coronary artery calcification. I have some difficulty with this concept of healing.
Yes. You're absolutely right.
Very few diseases are truly cured. Bone fractures, yes, but metabolic disorders are not cured either. But it doesn't sound so bad if I take medication for that my whole life. But if I have a disease like GIST, then I also cannot be cured anymore. If you can live well and take the tablets for it, that's already fine.
Exactly right. So we just said that healing is the wrong term, but you actually have a very good quality of life, can shape your life, go to work, hike, travel, or whatever. And you also have very elderly patients.
There's a whole group of patients who are well over 80 years old. Some of them have been taking imatinib for 10, 15 years, or even longer, and they're still in very good condition. They're living active lives, and the treatment is often well tolerated, even over such long periods of time. Of course, there are other ways things can go. We're certainly not going to deny that, but it doesn't mean everything always has to be so terribly bad. There are positive developments, and there are also negative developments. But there's no reason to immediately throw in the towel and say, oh God, how terrible is this now? I don't see the need for that.
Okay, I believe these are now, once again, some very positive final words. My sincerest thanks to you, Professor Hohenberger, for giving us the opportunity to discussing this today. Thank you.